had in the wards. Sorry. Okay, so it's a 27-year-old male. He's HIV negative. He's not an IV drug user. He hasn't traveled recently. And he presented with a 3-week history of loss of weight, fever, night sweats, difficulty swallowing, and then possibly double vision as well. Unfortunately, he was quite ill at the time of getting the history. So this is what we managed to get from him. I'm going to go through just the positive findings and not the negative examination findings. So generally, he was quite unwell. He had very poor dentition, and he had cardiovascular. He had signs which were concerning of an infective endocarditis. He had a Janeway lesion on the right thenar eminence, and he had hematuria of 1+, but no murmurs were clinically found. And on CNS examination, we noticed that there was some cranial nerve fallout. And incidentally, he had also, or rather I should say, he was initially at Victoria Hospital, and they were quite concerned of what looked like a cavernous sinus thrombosis, and were quite happy with the signs that they picked up clinically on him. And we noted a cranial nerve 3, but actually only ptosis on the left, no mydriasis. And then he had a cranial nerve 6 on the left, which was quite subtle. And then a lower motor neuron 7, which was a little bit unexpected. And then a cranial nerve 9 maybe complained of swallowing difficulty, but his Grag reflex was present. And then again, very subtle cranial nerve 12 weakness, left-sided tongue was weak. And importantly, also had chemosis on the left side, so in keeping with the cranial nerves. And he had a bit of a pronator drift on the right side, but normal power, and then abnormal joint position sense bilaterally, but normal light touch and pinprick. So obviously we were looking for any brainstem problems, but nothing really to go home about other than the fact that there are these cranial nerves, and importantly, no cerebellar signs. Okay, so as I said, he was labeled as a cavernous sinus thrombosis, sent across for further management. And I thought, well, let's just remind ourselves a little bit about the anatomy. So this is from Netta. I'm sure we all know him. We all used him when we were medical students. So he has the cavernous sinus. There's oculomotor nerve 3. And as I said to you, he just had a ptosis and trochlear nerve 4. So generally, those patients will present with a pupil that is upwards and outwards if they look straight, if they look directly towards you. And what's interesting about these patients is that when they do walk towards you, if they've only got a cranial nerve 5, they actually have to bend their head downwards so that they can see you with their left, well, their eye that has the cranial nerve 4 fallout. And then an abducens 6, which we thought that it was possibly there. And importantly, he didn't actually have any sensory changes in the trigeminal nerve over the ophthalmic or maxillary regions. So maybe he's got a cavernous sinus thrombosis. And then investigations, as I said, I'm only going to go through the positive findings. So high white cell count of 18. I did include an HB, so you could see 13.7, platelets of 2, urea of 36, creatinine of 158, INR was up, LDH is up, total bill is up, and RPI very low, which is quite intriguing. Not too sure where that came in. And then D-dimer's up, hapto's okay, and then as I said, he's HIV negative. So concerning blood results for a possible DIC with multiple organ involvement, abnormal liver function, but as you can see, his urea was up. Maybe he was just very pre-renal, secondary to him telling us that he had a difficulty swallowing, so probably not taking in enough fluids. But concerning his liver dysfunction was also there. His enzymes are relatively okay, slightly cholestatic picture. And his blood culture grew in Eikenella corrodens, and he had repeat blood cultures after that, because obviously with Eikenella corrodens, we're a little bit concerned about infective endocarditis as part of the Haysick organisms. And at one point, once he got better, we decided to do a lumbar puncture on him. And unfortunately, this was quite late in the day. And that's because of his platelets of 2, which took time to improve, as well as this INR, which is a bit borderline. And as you can see, glucose is 2.4, lowish. Unfortunately, I don't have a serum to compare it to. Protein of 0.81, elevated. Polys and lymphs are present. Cryptococcal antigen test is negative, and gene expert was negative. And then I'm going to take you through his radiological investigation. So chest X-ray, bilateral infiltrate. Importantly, he gets an echo because, as we said, we know this is part of the HACEP organisms. So we wanted to check if there's any signs of infective endocarditis. And again, not happy with this ejection fraction of 45%, not normal. And the CT brain I'm going to go through now. But importantly, I wanted to show you that there was a comment of mild cavernous sinus thrombosis, and this left sigmoid sinus thrombosis extending into the internal jugular vein. I'll show that to you now. And an MRI, diffusion restriction in the anterior left centrum semiovale extending into the anterior corona radiata, and no brain in-stem infarct. And again, I will show you what that looks like. Okay, so here's his chest X-ray. As you can see, the most pertinent thing that pops out at you is this abnormal chest X-ray with these bilateral infiltrates all over, and what also looks like a probable effusion on the left-hand side. There's blunting the costophrenic angle, and the chest X-ray wasn't in keeping with how he looked. He had an increased respiratory. It was very unwell, as I said to you earlier. And here is his CT brain. And as you can see over there, this is where your internal jugular vein is, and there they've marked it for us very nicely that he's got a thrombus inside there. And then an even nicer image that the radiologist did is there's a very large IJV thrombus sitting again on the left-hand side. And then this is what they were talking about in the brain with, on MRI with the infarcts that were seen in the semi-ovale area. Unfortunately, I can't show you the sigmoid sinus thrombosis because to my eye it was quite difficult to see. And then the cavernous sinus also wasn't the easiest thing to see, but the radiologists were quite convinced that it is probably there. But I'll get into that a little bit more. So here we go, putting the science together. So we've got this gentleman who's now presented to us with a Eikenella corrodens bacteremia with multi-organ involvement, liver, brain, kidneys, and lung involvement with these bilateral infiltrates, and this possibility of this being a cavernous sinus thrombosis. So I wanted to go a little bit more into that because as physicians are and as ID specialists are, we like to inspect and look further in and try to put the pieces together. And for me, not everything fitted very, very well. So try to explain, if this isn't a cavernous sinus thrombosis, what else could this be? So in chatting to the neurologist that was looking after the case, we thought it might be something else. So if you look at cranial nerve 3, as I said, he only had ptosis. So what about the fact that the internal jugular vein is quite close to the carotid, and that's where the sympathetic chain is? So possibly inflammation also around the cranial nerve 3 along the sympathetic chain, affecting and causing this ptosis. And then cranial nerve 6 and 7. Could this be part of meningeal inflammation affecting the cranial nerve on its way? And then, well, maybe it's cranial nerve 9, or is it just a sore throat? Because as we know, Eikenella is generally found in your oral cavity as well as in your genitourinary tract. So maybe the sore throat was actually just the Eikenella, or is it the internal jugular vein, which is also causing him to have pain in the neck? And then, as I said to you earlier, there were signs in keeping with infective endocarditis clinically. I mean, Janeway lesions, hematuria, not really clubbed or splinters, and again, no murmurs, and an echo that's a transthoracic echo that was essentially normal from a valvular point of view. But then how do you explain all these multiple CVAs? Is it part of this multi-system involvement with DIC, and he just gets as infarcts, or did he actually have infective endocarditis that we missed? And then how do we explain the lung findings? So from all those pulmonary infiltrates, So with what I think he has is a Lemierre syndrome with this internal jugular vein thrombosis, and those are prone to shooting off septic emboli to the lungs. So what do we do for him? So in the initial regimen, he was given ceftriaxone 2 grams 12 hourly, and that was because he was quite unwell. As I said to you, he also had a decreased GCS of around 14-ish. So we decided to rather give him meningitis doses to treat that. And then we changed him to ampicillin 3 grams 6 hourly. And then after going on a ward round with microbiology and us, we decided actually rather let's just go back to ceftriaxone. And unfortunately, the gentleman signed a red ticket. So he signed himself out of the hospital against our advice. And that was after 17 days of this treatment. So I'm just going to go a little bit into Eikenella and a little bit into the history. So it was actually first discovered in 1950 by Dr. Holm, and he originally called it corroding bacillus. And the reason why it was called corroding is because it causes these pits. It's a little bit difficult, like this not being a 3D image, but and I'm yet to see one myself, but you can kind of make out it's pitting in the agar over there. And then in 1958, this Dr. Eiken was the one who actually renamed it after himself into Eikenella corrodens. And then I wanted to go into, well, what groups of people get this disease? And this article by Sheng et al. Described patients that have malignancies, alcoholism, strokes, diabetes, congenital pneumonitis, chronic liver disease, chronic lung disease, and chronic valvular disease. But in essence, it's your patients who have risks of aspiration, such as alcoholisms, people who are alcoholics, as well as people who have problems with mucociliary clearance. So that would be a chronic lung disease, and patients who are immunosuppressed. And in this case, it was in their cohort, it was the diabetic patients. But in their cohort, actually only 62% of patients had some form of underlying medical illness. And of note, 8 had a recent tooth extraction. And the most common area of infection was in the upper respiratory tract, which is what we expect because it is one of the oropharyngeal organisms. Okay, and then this was an article by Udaka et al. in 2007 that was done in Japan, and their group is their study group is in an ENT department. So obviously we're going to find a bias towards people having upper respiratory tract infections, and all the specimens from there were from the upper respiratory area, and none of them were on blood culture. But what I find quite intriguing is 17 out of the 22 patients that had this Eikenella also had a co-infection with one of these other organisms. And it's thought that the Eikenella actually enhances the virulence of the streptococci, and these patients will present with larger abscesses, sicker, etc. And co-infection is not an uncommon thing. However, in our patient, his being a bacteremia, we actually only managed to isolate one organism, which was the Eikenella corrodens. Okay, so then, as I said, well, maybe this is all Lemierre syndrome, and this article by Gore was a meta-analysis, and they actually only, out of their 394 patients, only one of them had an Eikenella corrodens, Lemierre syndrome. And I just, for interest's sake, what I found quite interesting is these patients, they also reviewed the articles and looked at how many received anticoagulation and what were the outcomes, and with regards to mortality and with regards to recanalization of the vessels. And in actual fact, whether you got or whether you didn't get anticoagulation made no difference to those factors of the Lemierre syndrome. And then another two cases of Eikenella corrodens causing this, again, Lemierre syndrome. And then finally, another case also by Yamagishi, which actually had two organisms, so co-infection. So what I'm trying to say from this slide is that Eikenella is actually a rather uncommon cause of an internal jugular vein thrombosis causing Lemierre's. And as we all know, Lemierre's is, when we think of Lemierre's, we think of the Fusobacterium being the most common bacterium causing Lemierre's. Okay, and then I wanted to go into a little bit about, well, what are the treatments and why did we decide not to go for ampicillin and rather go back to the ceftriaxone. So I'm just going to go quickly through what they advise against giving. So there's resistance to the macrolides. So they don't advise giving erythrochloroethramycin or clindamycin. And what I find interesting from this article, it is old, 2007, but we were looking at the CLSI guidelines yesterday, and actually an MIC of less than 8 for chlorothromycin is sensitive, but I'm not sure what the CLSI guidelines were back then. So maybe this is resistance, and according to the authors, they did feel that this was a resistant profile. And also, what's interesting is metronidazole also is another antibiotic that you should not be giving to these patients. And it is interesting because it's an organism that's an anaerobe, and generally we associate metronidazole as well as clindamycin having pretty decent anaerobic cover. So yeah. Okay, so let's go a little bit more into the resistance pattern. So beta-lactamases are the concern, and that's why we weren't too happy to go with the ampicillin because of the concerns of developing infection. And one author, I'm not sure where they made this recommendation from, but they were saying that if the patient's not that ill, then you don't really need to worry about resistance, and then you can go with one of the beta-lactams. But if you are worried about resistance, then you should rather, if you are worried about a patient being very ill, then you should rather go with one of the cephalosporins in treatment. And then trying to find some data, there isn't a lot out there from what I could find. Shing et al. 2001, 43 isolates, all of them were sensitive to penicillins. And then Goldstein in 1978, 24 isolates, they were all sensitive to penicillin. And then this study by Lockerix in 1991, there were 44 isolates and all of them were resistant, but it's obviously a biased study because the study specifically looked at patients that had Eikenella corrodens that failed penicillin treatment. Okay, and then this is just for complete interest's sake. I think we all do know this, but for those that don't, it's just to go through the susceptibility patterns of the penicillins without clavulanic acid, and then those with clavulanic acid. And as you can see, the MIC 50, MIC 90, very high for benzyl penicillin. The minute you give some clavulanic acid, the MICs markedly decrease. Okay, so the summary of the treatment that we gave the patient, or the summary of treatment that you can give the patient is, if it's an infected bite, you can give a co-amoxiclav, and bites are usually from humans. However, there have been cases of people getting it from dogs. And also what I found interesting for those people that like to bite their nails, there was a case report of a patient that got Eikenella corrodens from nail biting. So stop biting your nails if you do. And then for infective endocarditis, ceftriaxone 2 grams daily, or ampicillin sulbactam, which we don't have, is the other option. So yeah, that is my talk in a nutshell. A very interesting gentleman who unfortunately we didn't get to figure out exactly what was wrong with him at the end of the day. And I'm still concerned that he probably had an infective endocarditis. Yeah, we'll hopefully we'll catch him later again if he hasn't demised by now. Thanks.
Thanks very much, Terry. A very nice presentation, and thanks for releasing your screen. So I'm sure there are questions. I mean, I have a couple. So, I mean, firstly, well, one question, one comment. The question is, in your reading, what was the mechanism for the enhanced virulence of streptococci in Eikenella co-infection? Firstly.
Thanks, Prof. So unfortunately, I couldn't get that article because it was back in 1980 or something, and I wasn't able to download that from the UCT site. But it was something to do with receptors. I just read the abstract, but I'll be lying to you if I tell you the exact the pathophysiology behind that. I don't know.
I don't know if one of our microbiologists wants to comment, but while they're thinking, I mean, you know, Lemierre syndrome, as you say, classically Fusobacterium necrophorum. But if you think about it, the possibility of actually culturing Eikenella, I mean, in general, obviously a lot of people presenting with sore throat will be given a penicillin or an aminopenicillin, which may, you know, make culturing difficult. So Fusobacterium may be not overcalled, but may become, you know, more prominent, whereas other bacteria that are sensitive to commonly prescribed antibiotics in the community might not be isolated. So it's just possible in that respect. I'm not sure how you would make the leap from it being Lemierre syndrome in the first place, so the Eikenella getting into the internal jugular and then obviously seeding the lung, but then how he gets you know, cerebral thromboses is more difficult for me to explain. He doesn't have a shunt, but I suspect you're right that he does have endocarditis. In fact, maybe very small vegetations. Janeway lesions, you know, aren't pathognomonic of endocarditis. Can be from, you know, from an embolism other than from the actual heart valves. But yeah, so that's what I would think. Graham, you have your hand up?
Yeah, thanks, Terry. A really interesting case, and just to get a sense of his clinical response to the antibiotics. You said he was, by the time he signed the red ticket, all his disease severity parameters were improving. When you said the platelet count had come up, as his temperature settled, etc.
Yeah, Prof. Unfortunately, I wasn't there when he was the few days before he signed his red ticket, but he was showing marked improvement the last day I saw him. His GCS improved to 1515, and he was just becoming a lot more irritated by being in hospital. So yes, and his platelets and blood parameters did start to improve as well.
Yeah, because just you know, one thought I had is to me it does seem very convincing for Lemierre syndrome. And whether there wasn't co-infection with Fusobacterium, but that wasn't cultured. But, you know, that's less likely if he was clinically improving. So, you know, there was just a thought as you were talking, if he had improved despite, you know, not being on anaerobic cover. But, you know, I mean, I think the penicillins are thought to have some effect against Fusobacterium. And perhaps Ceftriaxone does as well. So, you know, you might not have cultured the Fusobacterium, but the Fusobacterium is thought to be, you know, implicated in about 80% of cases, and then could be a portal of entry for another organism. So that's one thought. The other thought is I'm not convinced that you have to implicate an endocarditis here. I mean, you looked hard for endocarditis, and there were no vegetations. He had a platelet count of 2, and that could give him, you know, thrombocytopenic purpura. Was it really a Janeway lesion, or was it just a bleed from a platelet count of 2? And the same thing for the hematuria. Yeah. And then were the strokes kind of venous infarcts?
So from my understanding, they looked more like arterial infarcts. And when I spoke to the neurologist, he said to me, "Listen, Terry, this guy I'm very worried he's got infective endocarditis because it's in multiple areas." So yeah. And then I completely agree, Prof. It's definitely the low platelet count with the Janeway lesions, yes, definitely possible. I agree.
Yeah, but I mean, the only thing that's a little bit strange about that is that I think that was the only lesion he had over the thenar eminence. He didn't have any other. So I mean, for it to be thrombocytopenic purpura relating, you know, I would have expected one or two more lesions. Who knows? You're right, Graham. I mean, it doesn't have to be invoked. It could have been the low platelet count, but it's just. He also had hematuria. Again, I suppose you could argue it.
I think probably the most difficult thing to explain is the infarct. Then, if they weren't in a venous infarct pattern.
Yeah. Sean and then Chad.
Thanks. Yeah, I also wanted to ask about his state when he was discharged, but you've kind of addressed that. I mean, he had widespread thrombosis, and that could be a feature of the DIC, because I mean, it's fairly convincing that he had a DIC pattern. And so that could perhaps be explained on the basis of just aberrant response to infection and DIC. And then, Terry, I had a question about the slide that you put up of the MIC on that one. I don't know if that was a review or just a collection of isolates from one study. Maybe you can put that up. I mean, my question is about what those MICs were. Were those just a median of the MICs from those isolates that they collected in that study, or were they just reporting what they thought the breakpoint should be? This slide.
Okay.
What is this?
Yeah, so my understanding was this is what they found in their study. Not comparing it to other isolates.
Okay.
Yeah.
So the MICs to penicillin were quite low. And are there published breakpoints?
Sure. I'm not too sure. Maybe Chad can help us on that one.
Yes, there are. CLSI do have published breakpoints, but very specific methodology. So they're quite fastidious organisms, and they don't grow very well in the broth microdilution method that's recommended. So a lot of these, these surveys that they've done, they get a lot of failures with no growth in the control wells. So if it's difficult to do under those experimental conditions, it's even more difficult to do on in a routine setting. We don't get that many HASIC organisms, so we just did a little extract of 5 years worth of data in anticipation of the talk, and we just found 3 cases of HASIC bacteremia over 5 years. 2 with Eikenella, just pulling it up here. And thanks to Lemierre for helping with this. 2 with Aggregatibacter and 1 with Eikenella. So we don't offer those methods here, and I think probably unlikely to. I think the recommendations and the surveys have found ceftriaxone is routinely appropriate. And then in terms of the enhanced virulence, I think a lot of the HASICs do occur in polymicrobial infections. In fact, Aggregatibacter actinomycetum comitans is called that because it co-occurs with actinomyces. So I suppose, gram-positive organisms are good. They express a lot of cell surface proteins, adhesins, especially for like oral mucosa attachment and heart valve attachment, and perhaps they're setting up like a niche or a biofilm for the less adhesive gram negatives. That's my guess.
Thanks, Chad. I mean, again, I don't think, I think the fact that we have so much culture negative endocarditis because of prior antibiotics before cultures are taken probably underlies the rarity of the HASEC organisms. I mean, so I'm sure we probably have more endocarditis related to HASEC, but we just don't pick it up. Although, of course, it's going to be less than the sort of standard streptococcal. Chad, your hand's still up, but I take it that's an old hand. Unless there are any other questions, we'll move on. But that's a really, nice and interesting case, Terry, and thanks very much for all the work in putting that together. I do appreciate it.
Thank you.
We're going to move on to our next presentation. I'd really like to thank Paul for taking this on. Paul started 4 days ago and, was